Welcome to our open online course. This is the first lecture of this educational material related to Parkinson's disease. In this session, we will discuss about global facts for Parkinson's disease, the cause and pathogenesis of the disease, the diagnosis, the symptoms, and the expected influence on patients' and caregivers' life. We will also discuss about how a physician should disclose the diagnosis of Parkinson's disease to patients and carers, and about the importance of timely integration of palliative care. First of all, some global facts about Parkinson's disease. James Parkinson, an English surgeon, published in 1817 an essay on the shaking palsy. Parkinson's descriptions were very accurate about the cardinal symptoms of the disease, but before him others had already described features of the disease that would bear his name. Parkinson's disease was then known as paralysis agitans, shaking palsy in English. The term Parkinson's disease was coined in 1865 by William Sanders and later popularized by French neurologist Jean-Martin Charcot. Parkinson's disease is a progressive neurodegenerative disease. It has a gradual onset of symptoms and a progressively deteriorating course. The term neurodegenerative refers to disease mechanisms that cause progressive loss of structure or function of neurons, including death of neurons. Even today, more than 200 years after the description of the disease, its etiology remains unknown. However, we know that there are genetic risk factors and environmental risk factors that together lead to the loss of structure and function of neuronal circuits observed in Parkinson's disease brain. Today, Parkinson's disease affects about 10 million people worldwide, since there are 1 to 2 patients per 1,000 of the population. The prevalence of the disease increases with age and is estimated to be 41 people per 100,000 in the 4th decade of life, 1,900 people per 100,000 in the 8th decade of life, and men-to-women ratio is 2 to 1 in Europe. There are numerous disorders causing symptoms mimicking Parkinson's. You can see on the list some of these disorders, but the detailed description of them is beyond the scope of this lecture. It is important, however, to keep in mind that the term Parkinsonism is used to indicate a patient with symptoms similar to Parkinson's disease. Early in the disease process, it may be difficult to distinguish between Parkinson's disease and Parkinson-like diseases. Frequently, the correct diagnosis can only be made after monitoring the course of the disease. Let's see now what we know today about the causes of Parkinson's disease. As we said before, the exact cause of Parkinson's disease is currently unknown. But we know that there are several genetic and environmental risk factors. Regarding the genetic factors influencing the development of Parkinson's disease, the year 1997 marked the starting point for Parkinson's disease genetics with the identification of mutations in SNCA gene, encoding alpha-synuclein. This key first finding to suggest a heritable component of Parkinson's disease was followed by the identification of additional rare recessive and dominant forms associated with early-onset familial cases of Parkinson's disease. To date, Parkinson's disease-causing mutations have been identified in 15 genes responsible for monogenic forms. However, these mutations can explain less than 5% of the total cases. The vast majority of cases of this disease belong to the common, sporadic, idiopathic form of the disease, and they are considered to have genetically complex inheritance associated with an interplay of genetic risk and likely environmental influence. The monogenic forms can be either autosomal dominant or recessive. They are related to several different loci involved in monogenic forms of Parkinson's disease, characterized as Park1, 2, 3, 19. These loci are found on the genes SNCA, encoding A-synuclein, PRKN, encoding Parkin, DJ1, encoding DJ1, PINK1, encoding TAN-induced kinase 1, LRRK2, encoding Dardarin, VPS35, encoding vacuolar protein sorting 35, and GBA, encoding glucocerebrosidase. All known monogenic forms of Parkinson's disease explain only 30% of familial cases. On the other hand, For the common polygenic forms, several susceptibility genes and numerous risk loci have been identified to date. Association of sporadic Parkinson's disease with single nucleotide polymorphisms on genes related to monogenic forms of Parkinson's disease has been overwhelmingly established in genome-wide association studies. So far, many genes have been involved, including SNCA, LRRK2, GBA and MAPT. However, only a small proportion of the phenotypic variability has been explained by genetics. And this is probably because the combination of many genetic and environmental factors lead to Parkinson's disease. Regarding environmental and behavioral risk in the development of Parkinson's, there are several factors that seem to modify the risk. However, the data are still inconsistent and controversial for most of these factors. Increased risk for development of Parkinsonism has been reported in relation to heavy metals, for example iron, copper, manganese, mercury, and lead. But also pesticides, for example, MPTP, 2,4-D, periquat, permethrin, dieldrin, diquat, maneb, mancozeb, rotenone. And illicit substances, such as amphetamine, methamphetamine, cocaine. On the other hand, decreased risk for development of Parkinson's disease has been reported in relation to increased coffee use, smoking, urate intake, and physical activity. Only physical activity has been repeatedly shown to lower the risk. Even for individuals that finally develop Parkinson's disease, the prognosis is better for those who had rigorous physical activity in their life. Gene-environment interactions are understood to be the underlying cause of idiopathic Parkinson's disease. Human genotypes are independently unique, and individuals exposed to the same environmental factor are affected differently, resulting in diverse disease phenotypes. The combined effect of genetic and environmental factors may influence the onset of human disease by structurally altering deoxyribonucleic acid, DNA. For example, caffeine is an adenosine A2A, ADORA2A gene, receptor antagonist, which increases dopamine neurotransmission. Polymorphisms of ADORA2A have been found to reduce the risk of Parkinson's disease. In contrast, pesticides and heavy metals display a negative effect and increase Parkinsonism by causing gene variations linked to familial Parkinson's disease, for example, PARK1, LRRK2, PINK1, resulting in disease-associated mechanisms such as mitochondrial dysfunction, oxidative stress and protein degradation impairment. So, these interactions lead to the initiation and propagation of the pathogenetic cascade. This pathogenetic cascade includes the following steps: alpha-synuclein aggregation leading to fibril formation, dysfunctional autophagy, and lysosome pathways, defective intracellular trafficking, dysregulation of calcium signaling, mitochondrial dysfunction, and mitochondrial oxidative stress. Pathogenetic mechanisms lead to protein aggregation and Lewy body formation, that are structures rich in asynuclein aggregates. Finally, these mechanisms result in the neuronal degeneration and cell death. But dopaminergic neurons in substantia nigra pars compacta seem to be very vulnerable in these pathologic processes, and this is probably caused by a convergence of their peculiar phenotype, as in pathology and mitochondrial dysfunction. Later on, the pathology gradually spreads to the whole brain. The selective and severe degeneration of dopaminergic neurons in SNC results in basal ganglia networks breakdown. Dopaminergic fibers from SNC target mainly neostriatum, and have a modulatory role on striatal medium-sized spiny neurons. Those neurons are the central component of the basal ganglia networks. They receive excitatory input from thalamus and neocortex, modulatory inputs from SNC and inhibitory junctions from intrinsic striatal neurons. With the disruption of dopaminergic input into medium-sized spiny neurons, the whole network collapses and the Parkinsonian symptoms start. We go on to the diagnosis of Parkinson's disease. Parkinson's disease is a clinical diagnosis. According to the recent MD's Parkinson's disease criteria, the first essential step towards the diagnosis of Parkinson's disease is the detection of Parkinsonism, which is defined as bradykinesia, in combination with at least one of rest, tremor or rigidity. In the picture you can see the typical appearance of a patient with Parkinson's disease while walking, with bent posture, absence of the automatic upper extremities movements and difficulties to start moving. Parkinson's disease is the most common cause of bradykinesia with rigidity or resting tremor. However, as we mentioned before, there are numerous disorders causing symptoms mimicking Parkinson's disease, and sometimes it is difficult to distinguish Parkinson's disease from other causes of Parkinsonism. The most important PD mimics include essential tremor, drug-induced Parkinsonism, vascular Parkinsonism, dopa-responsive dystonia, and atypical Parkinsonian disorders. That is why we need diagnosing criteria, and it is important to accurately describe the clinical findings, collect history of the disease and monitor the course. So, once Parkinsonism has been diagnosed, diagnosis of clinically established Parkinson's disease requires absence of absolute exclusion criteria, at least 2 supportive criteria, and no red flags. Once Parkinsonism has been diagnosed, diagnosis of clinically probable Parkinson's disease requires absence of absolute exclusion criteria, presence of red flags counterbalanced by supportive criteria. If one red flag is present, there must also be at least one supportive criterion. If 2 red flags, at least 2 supportive criteria are needed. In general, no more than 2 red flags are allowed for this category. It is obvious that in order to set an established or possible diagnosis of Parkinson's disease, it is important to exclude other possible diagnoses related to Parkinsonism. So we have absolute exclusion criteria. The presence of any of these features rules out Parkinson's disease. 1. Unequivocal cerebellar abnormalities, such as cerebellar gait, limb ataxia, or cerebellar oculomotor abnormalities, e.g., sustained gaze-evoked nystagmus. Macro square wave jerks, hypermetric saccades. 2. Downward vertical supranuclear gaze palsy, or selective slowing of downward vertical saccades. 3. Diagnosis of probable behavioral variant frontotemporal dementia or primary progressive aphasia, defined according to consensus criteria 31 within the first 5 years of disease. 4. Parkinsonian features restricted to the lower limbs for more than 3 years. 5. Treatment with a dopamine receptor blocker or a dopamine depleting agent in a dose and time course consistent with drug-induced Parkinsonism. 6. Absence of observable response to high-dose levodopa despite at least moderate severity of disease. 7. Unequivocal cortical sensory loss, such as graphesthesia, stereognosis with intact primary sensory modalities, clear limb ideomotor apraxia, or progressive aphasia. 8. Normal functional neuroimaging of the presynaptic dopaminergic system. And finally, documentation of an alternative condition known to produce Parkinsonism, and plausibly connected to the patient's symptoms, or the expert evaluating physician, based on the full diagnostic assessment, feels that an alternative syndrome is more likely than Parkinson's disease. Then, supportive features, like clear and dramatic beneficial response to dopaminergic therapy. Presence of levodopa-induced dyskinesia. Rest tremor of a limb documented on clinical examination, or the presence of either olfactory loss or cardiac sympathetic denervation on MIB scintigraphy can help to support the diagnosis. On the other hand, there are some red flags against the diagnosis of Parkinson's disease, like the rapid progression of gait impairment, severe autonomic failure, a complete absence of progression of motor symptoms, early bulbar dysfunction, inspiratory respiratory dysfunction, recurrent, greater than 1 per year, falls because of impaired balance within 3 years of onset. Disproportionate anterocollis, dystonic, or contractures of hand or feet within the first 10 years, absence of any of the common non-motor features of disease despite 5 years disease duration. Otherwise unexplained pyramidal tract signs, bilateral symptom onset for symmetric Parkinsonism. For the diagnosis of Parkinson's disease, the presence of red flags has to be counterbalanced by supportive criteria, but in any case no more than 2 red flags are allowed. Currently, laboratory tests are only useful to rule out other disorders or aid the diagnosis in atypical cases. Blood tests, brain imaging, CT and MRI brain scans, radiotracer imaging, PET and SPECT. Despite the effort made with the establishment of widely accepted diagnostic criteria, the accuracy of clinical diagnosis remains about 80%, in studies that used autopsy examination as confirmation. Continuous diagnostic re-evaluation process improves diagnostic accuracy. Various biomarkers, such as clinical, biochemical, neuroimaging, genetic or digital, are currently tested for the diagnosis of Parkinson's disease, but not yet implemented in daily clinical practice. Let's discuss now about the symptoms of the disease. The symptoms of Parkinson's disease can be classified in motor symptoms and non-motor symptoms. Motor symptoms include the cardinal features: bradykinesia, slowness of movements; rigidity, increased muscle tone; resting tremor; and later postural instability. Secondary motor features include hypomimia and glabellar reflexes, dysarthria, dysphagia, sialoria, micrographia, shuffling gait, festination, freezing, dystonia. Non-motor symptoms include autonomic dysfunction, gastroenterology symptoms, cognitive dysfunction, mood and behavioral abnormalities, sleep disorders, sensory abnormalities, anosmia, paresthesias, pain. Motor and non-motor symptoms may present at any time in the course of the disease. The following symptoms are considered prodromal and may present before the cardinal motor symptoms: subtle decrease in hand dexterity or mild tremor, decreased arm swing on the first involved side, soft voice or decreased facial expression, sleep disturbances, decreased sense of smell. Symptoms of autonomic dysfunction, including constipation, sweating abnormalities, sexual dysfunction, and seborrheic dermatitis. A general feeling of weakness, malaise, or lassitude. Depression or anhedonia, and slowness in thinking. But what is the expected influence of Parkinson's disease on patients' and caregivers' life? The following facts explain Parkinson's disease's prognosis. Parkinson's disease has a progressively deteriorating course without a cure to date. At the initial stages, symptoms are mild and respond very well to dopamine replacement treatment, offering to patients and caregivers satisfactory quality of life. With the progression of the disorder, symptoms aggravate and response to treatment presents worsening fluctuations and is complicated with the appearance of abnormal involuntary movements, dyskinesia. At the final stage of the disease, patients' mobility is significantly reduced, and non-motor symptoms are very often equally severe. Parkinson's disease is a multi-system disorder causing also dementia, mood disorders and gastrointestinal disorders. Furthermore, it is related to increased risk of comorbid conditions, like infections and fractures. All these constitute an important deterioration in the quality of patients' life, and pose a heavy burden on caregivers' life. Let's see now how we should inform the patients of their diagnosis. Once completing the diagnostic approach, physicians have to let patients know about their diagnosis. There is no easy way to tell patient the diagnosis of a neurodegenerative disorder. While telling the diagnosis, it is important that physicians take an adequate amount of time, convey empathy, have physical contact with the patient, speak plainly and answer all patients' questions. Then, physicians should give their patients some time, a week or a month, to get used to the first news before discussing prognosis and possible future life changes. Patients at the initial stages of the disease, without serious cognitive or behavioral disorders, can decide if they want any close relative to be informed by the treating physician about the diagnosis. Or they may wish to find a convenient moment to announce the diagnosis by themselves. For patients with dementia and/or severe psychiatric disorder, the treating physician must inform a close relative about the diagnosis. Physicians should always give family members and caregivers some time, a week or a month, to get used to the first news before discussing prognosis and possible future life changes. The gradually progressive nature of Parkinson's disease, with insidiously increasing disability, makes it challenging to clearly define the onset of palliative care needs for patients with Parkinson's disease. The modern palliative care concept is no longer restricted to the final stage of disease. Palliative care involves incorporating a continuity of care, effective management of the chronic palliative interface, and a multidisciplinary network of professionals working both in the community and in specialized clinics, with active involvement of caregivers, which we will discuss in Lesson 2. Thank you for listening.